And now, please welcome Commander J.P. Chrétien and Dr. Matt Turek.
So Matt and I are delighted to welcome you to this panel on saving lives on the battlefields of the future. As a quick personal background, I'm a Navy physician, and my Navy career has been all about protecting the health of military service members. I've done that in my various assignments as a medical officer, a researcher, an advisor, and that's what I focus on at DARPA, biomedical technologies in particular, to detect and treat and prevent health threats of military and national security importance. And Matt, I'll turn it over to you for intro.
So I'm Matt Turek, the Deputy Director for the Information Innovation Office at DARPA. I think you heard quite a bit from me yesterday, but in terms of personal background, I come to these problems with a computer vision and machine learning background, also informed by some experiences early in my career. I spent a number of years at GE Medical Systems, now GE Healthcare. That gave me some appreciation for some of these problems. In addition to being the Deputy Director of I2O, I'm also a Program Manager in DSO, in the Defense Sciences Office. And I own that program that I mentioned yesterday in the moment, which is looking at AI decision-making around triage on the battlefield.
So today we're going to explore next generations of technologies that are going to be needed to save lives in future combat scenarios. And while DARPA does have a particular interest in the battlefield, some of the challenges and potential solutions we talk about may carry over to civilian settings as well. So that might be something we're able to tease out in the conversation. Where is that overlap, and where are their distinct needs? Innovating in military medicine is not new for DARPA. DARPA has a long track record here, from revolutionizing prosthetic devices to establishing the foundations for robotic surgery, telerobotic surgery, bioelectronics for better wound healing, multiple innovations to improve survival in patients who are bleeding. And bleeding is the number one cause of potentially survivable death and trauma in both military and civilian settings as a point of commonality. And so the overarching question for our discussion today is, what should we be doing next? As we look ahead to future battlefields and the medical situation there, we may see a picture that's a bit different from what we've become accustomed to. So I was a medical officer in Afghanistan about a decade ago, and by that time, this was a very mature combat theater. We had a highly effective medical evacuation and medical care system. Our pilots, our medics could get an injured warfighter to a forward surgical facility, forward hospital, in a matter of minutes. And that was key to the very high survival rate, because minutes make the difference between life and death. You've got to get to surgery quickly, get blood products on board quickly. This was the whole idea behind the golden hour. But the future may be different, and so today we're going to explore what that might look like and what sorts of biomedical tools we might need to rise to that challenge. But it's not just the biomedical, and one of the great things about DARPA is that DARPA brings together people with different expertise, different perspectives, and gets them to work together in an interdisciplinary way to solve complex problems. We've seen that throughout the DARPA Forward Conference, and we're going to get a sampling of that in the panel today. And so, Matt, I'll turn it over to you for those other equally important domains that intersect with the medical here.
Sure. I just want to emphasize that this is really an interdisciplinary problem set, right? So you need to understand the medical perspective, and we'll hear some of that today. We need to understand what sort of interventions are possible we need to understand how humans behave in these sorts of situations. And then, one of the topics that's close to my heart is, are there interventions or are there capabilities we can provide from an AI perspective that might help improve decision making? So I think there's a really diverse set of topics here. They all interlock and cross-connect, and hopefully we can make that evident during some of the discussion today. So with that, I think we've got a great set of panelists for you, and so why don't we bring them out and get started.
Well, welcome all. Why don't we start with quick introductions, and then we'll get into the conversation. Stacy.
Good morning. I'm Stacy Shackelford. I'm a trauma surgeon with the Air Force, and for the last 4 years, I served as the chief of the Joint Trauma System with the mission to improve trauma care on the battlefield and set up the learning trauma system for future cyclic improvements.
Hi, good morning, everyone. I'm Ron Poropatich, pulmonary critical care medicine trained, Army retired, and now at the University of Pittsburgh, where I serve as the director of the Center for Military Medicine Research, where we try to facilitate collaborations between industry, academia, and government to solve military medical problems.
I'm Michael Van Lent. I'm the CEO and president of SOAR Technology. I've dedicated my career to building human-centered AI for the military's toughest problems, which this is definitely one of.
Good morning, everyone. I'm Neil Shortland. I'm the director for the Center for Terrorism and Security Studies. And I'm a psychologist who has principally focused how people make decisions under high uncertainty and often when they are facing options that presents no clear good outcome, no clear best. And we hopefully will be talking a lot more about that and the role of technology across this panel.
Okay.
So with that, why don't we get started with, really the starting point is what are we trying to achieve? What are we trying to do? Ron, do you want to start us off in that direction?
Yeah, thanks, Matt and JP, for the opportunity to be here with this distinguished group of panelists. Some of the thoughts you've already heard from an operational warfighter perspective. You saw the OV-1 figure earlier, a lot of unmanned aircraft, flying manned aircraft. Stuart Young talked from the TTO on the vehicle ground autonomous systems. And so what we are learning is that a lot of the military has a lot of understanding on what's needed in the future battle space, but they're still looking for innovation and solutions. And I think the DARPA program can hopefully close the gap in some of what we want to do and what's currently available. I think the current conflicts in Ukraine and Syria are really predicting also and enlightening some of that doctrine that's already been thought through from the DoD. What we have seen so far in Ukraine, the first 100 days, 280 hospitals were bombed. The Red Cross symbol, Red Crescent symbol really doesn't mean much to a peer nation who is causing war in Ukraine. Same situation going on in Syria. A lot of the hospitals were bombed and destroyed there. And what that means is that mobility is going to be key for not only the warfighter, but the medical. Jordan and Estonia have tracked vehicles with medical, surgical, resuscitation capabilities. We know that we need to clear the battle space, and moving casualties quickly from the battle space to the rear echelons are going to be equally important. That's where unmanned air and ground vehicles come into play. How we care for those casualties en route is going to be really important. How we use autonomous systems to tell us that this casualty, using some autonomously driven algorithm, clinical decision support tool that says this casualty is going to crash and burn on this 40-minute flight, whether it's manned or unmanned. Don't put him or her on. Let's stabilize them and take other casualties. A nice review in Military Med last year talked about 1,500 casualties and showed that of the 1,500 during a 3-year period, 50% of them required no in-flight life-saving intervention. That means that future wars, maybe a significant percentage, can go on an unmanned vehicle, air or ground, to be evacuated. That also draws in the need, though, for on the ground, with a lot of casualties, the need for autonomous systems. You're going to have now an opportunity with big pre-data sets. I think what's really important, what we don't see, is enough warfighter pre-hospital data. And I know there's interest in DARPA in pursuing that topic area. And that's an important area because that will inform, with large data, clean data, these kinds of AI systems that will lead to clinical decision support. Bundled with that will be the need potentially to have robotic interventions. There are medical robotics and autonomous systems programs in the DoD, and that whole capability of medical robotics and autonomy in the future fight is going to be really key, I think, to how we pursue medical care on the battlefield and during the evacuation platforms, whether it's manned or unmanned. And then the long-haul evac on the back of a C-17, flying 50, 100, 200 casualties back to even a higher echelon of care. So all these different echelons of care are going to be critical as to how we solve the problem on the battlefield as well.
Mm-hmm. So that was a great articulation of a lot of things that we might want to go after. That actually really supports the way that we think about problems at DARPA, right? So the first question we ask ourselves is, what are we trying to do? You know, if you unpack what Ron said, there's a whole bunch of opportunities there. But one of the next things we think about is, you know, how is it done today? What are the limitations? What are the challenges? Also, that includes, you know, how has it been done in the past? Are there lessons that we need to learn from the past? So, Stacy, I know you've thought about this. What have we learned, or what should we learn from previous conflicts?
Yeah, I mean, it is really hard for me to think about such wazoo sort of technology in the future getting implemented on the battlefield, because it's so far from what we have now. And, you know, I think in the field of trauma surgery and trauma medicine, a lot of the advances that occurred worldwide started during conflicts. And you know, I was interested yesterday when we talked about the leaps and bounds and then the gradual improvements in betweens. And most of the greatest leaps in trauma medicine came during the conflict. So, you know, kind of going back to the Civil War, we got anesthesia. World War I, we had the advent of whole blood transfusions. World War II, it was antibiotics and the evolution of the combat medics. And then Korea, Vietnam was really the evolution of medical evacuation by helicopters. And you know, all this eventually moved over to the civilian side. In the recent conflicts, critical care air evacuation was a big game changer. Damage control surgery, damage control resuscitation, which was a little bit of back to the future, like we rediscovered whole blood, and tourniquets as well. And so, you know, then you think about, well, what is the next big leap that's going to occur? It kind of seems like all the sort of low-hanging fruit has been cleared. You know, we're back to stopping bleeding, giving blood, and evacuating patients. But the next big leap, I think, is going to be, you know, the technology that's going to have to somehow make it onto the battlefield. It needs to get to the earliest time frame immediately after injury. I mean, we're still waiting for, like we love to joke about the injectable nanorobots that are going to somehow stop bleeding, but actually maybe this is the group of people that's finally going to come up with the injectable nanorobots that are going to stop bleeding. And then, you know, blood substitutes,
So I think, you know, one of the other important things to understand here is sort of the role of the human in this context, and then also, you know, I think we'll get to sort of the role of AI. But you know, Neil, what can you tell us about the role of human and some of the challenges that they face in these situations?
Thank you. I mean, I think when we look about the development of technology and some of the topics that were talked about over the last day or so, it mirrors a lot of the way that we think about human decision making. We started off with rule-based decisions. We started off with creating those rules, with doctrine, with SOPs. Then we moved to experience, and as Mike Matthews would call it, the library of experiences. But what we've really studied and what we've investigated with soldiers and other domains is this issue of choice. The idea that you are facing a moment where you don't have anything internal or external that tells you that A is better than B or B is better than A. And as someone who's interviewed soldiers and worked in this area, a lot of soldiers, you know, Gary Klein noticed it, soldiers used to say they'd never made decisions. My soldiers would say, I've never made a decision. And that's through the amazing work of doctrine and technology and recognition. But they have occasionally had to make choices. And that's a different psychological construct. It's a different mode of thinking. And I think as we talk about these uncertain environments, we talk about new battlefields, we talk about new types of injuries, new technologies, choice may be more prevalent. It may occur more often. And then there's big questions in that for technology, because the issues humans make when they're faced with choice are new. It's not about right and wrongs. It's about inaccurate perceptions of how complex things are. It's about acting correctly but not in the right amount of time. It's about values. It's about morals. And then how do we sort this issue that choice is deeply personal? As a psychologist, I really enjoyed studying choices, because I felt that when someone makes one of these in-the-moment choices, it's a reflection of everything they were up to that point. They bring everything with them. They bring who they are, what matters to them. They're deeply significant personal moments in their life. How does AI help that? And better yet, who decides what is right then? Because you talk to a tactical officer who will tell you about the choice they made, and they will openly tell me it was the different choice that their commander would have wanted or Stratcom would have wanted, but to them it was right. And so now, whose values do we align to when people disagree within a team or between levels of a team? And so the more we unpack that psychology and those issues that emerge when people are in uncertainty, difficult situations with low resources, decentralized, more autonomy, all of that is new questions now to build into either how the AI does it, which may be the future, or how the AI helps the humans do it, which may be the more immediate thing to grapple, but I don't think is any less of a complicated question.
Yeah. So Mike, do you have thoughts?
So building on that, it's hard to imagine a domain for AI for which the stakes are more immediate and higher than battlefield medicine, triage, right? That combat medic sitting next to a friend that's been injured and literally, his or her life is in that medic's hands, right? That is one of the most immediate and highest stakes applications of AI I can imagine. At the same time, it's also hard to imagine a domain or a problem for AI for which the human-centered piece of that is not more critical, for a lot of the reasons Neil mentioned, right? It is obviously a hugely stressful situation, very, very high cognitive load. You have decisions that are going to have very literally life or death implications on people that you often have close personal relationships with. You have morals, you have ethics, you have long-term kind of implications of this. And so how you build an AI system that can help a human make the right choice or the right decision, and taking all these factors into account, even just the most effective way to communicate with the human in this situation is a big challenge. And then all these underlying factors that are coming into play, especially in a domain where the right decision isn't clear, and whatever decision or choice is made, there are counterfactuals, there are other things that you could have been done that you'll never know how they would have turned out. This is just a very, very hard, but also very, very important application for AI, whether it be the decision support system that's helping that combat medic, or the AI behind the autonomy that's making decisions about, where to take a casualty or what treatment choices to make along the way, right? These are decisions that come with stakes and come with human dimensions in terms of morals and ethics and trust and all that kind of stuff. It's such a important but also such a challenging application for AI. It's part of what just gets me really, really excited about this area.
Well, we're seeing AI, I'm sorry, Stace, we're seeing AI already in healthcare, so it's evolving, especially in the imaging field.
Yep.
So ophthalmology, pathology, radiology, dermatology, AI is becoming much more prevalent. So I think that will allow more acceptance, right, over time. And then you start pushing that far forward onto the tactical edge, as we say, right? So you start, once you do it in your peacetime setting, then, and you build that trust, that trustworthy AI, then you can start pushing it forward. And the training as we fight mentality of, look, I use it stateside, no matter where I am, I trust it, I'm going to use it, and I know how to use it. I think that's going to be helpful.
But I think one of the mistakes I tried, when I talk to people that are developing technology, trying to push it too close to the point of injury, I think, is really a mistake. It's like, really, we need to think about, what is this capability and where would it best be used on the battlefield? And like at the point of injury, when you talk about AI and decisions, we try to actually offload the medic's decision by just only giving them like one thing to do: stop bleeding, and maybe clear the airway. And the medics really talk about muscle memory. Like they have to have done this one thing like hundreds of times in training. And so like just feel like adding some external stimulus to that environment that really is unnecessary right after injury. However, certainly these environments that you anticipate in the future where you may not actually be able to evacuate the patient. And so now that medic, after he stopped the bleeding and has a live patient, the patient didn't bleed to death, I did that, I saved him. Now I'm stuck with him. Now what am I going to do? I wonder if he has a brain injury. I wonder if he's bleeding internally, or how can I get better diagnostic equipment? How can I communicate with a higher level of care? I think that is really more the role. In a more sort of slow-moving, lower threat environment where they're not immediately right after injury is really the role, the time for just do this one thing and don't think about it.
I think if we go into it with cognitive offloading and human in the loop initially, we're on safe ground. It's when everyone says right up front, no, we're going to do this fully autonomously, that you begin to lose confidence with the person proposing that solution.
And I think in the changing battlefield of the future, right, the role, as you're saying, of that medic is going to change, right? It's been, when we have air superiority, it's solve the immediate issues and get them, the casualty, evacuated, right? If you don't have air superiority, we're seeing Ukraine doesn't have air, or Russia, neither side has air superiority, right? Suddenly that casualty is with the medic for a much longer period of time, and the range of situations they need to deal with is probably broader than it's easy, for them, and they have the cognitive bandwidth to be prepared for. That's where I think there's the opportunity for decision support to play a role. Of course.
No, I 100% agree. And I think one of the things I think a sensible starting point is to think about, well, when people are in uncertain environments, new environments, where they're having to think outside of what they've trained, and maybe outside the tactical life-saving triage part of this, what are the flaws they often make? Well, it's things like not correctly perceiving the situation and not really thinking about the real outcomes. And that is a computing issue, that's a cognitive load issue, that's potentially an AI issue, right? It's about reevaluating the situation and knowing when things have actually changed, when your first perception, your first thought no longer applies. And, there's a lot of work that most errors don't come from getting it wrong the first time, they stem from not reevaluating the third time and getting it wrong then. But then what's really interesting about choices, when you watch people do these kind of decisions, when you observe them or study them in the real world like we have, or the training events or the simulations, is the issues that people have when they're making these decisions vary between them. So the flaws of one human in these kind of new and novel environments will not be the same as the flaws of another human. Some will want too much information to the point where they won't make a decision because they are constantly trying to find out what is going on in a situation where you just can't. Others will abandon any pursuit for information because their perception is there is just such an immediate need for action that they don't invest 10 minutes and radically change their understanding of the situation. So when I think about AI and partnerships and teaming in these environments, already we need to think about AI needs to be adaptive to the individual that it's working with, because their flaws in these moments are going to vary, and you obviously don't want to mismatch an AI giving you more information if you're the type of person and the type of individual whose flaw is always wanting more at the cost of actually making that time-sensitive decision that is needed in these kind of battlefield environments.
Yeah, and I think there's an interesting balance and tension there for the AI. On the one hand, you want to understand the human and their decision-making style, because to some extent aligning with their decision-making style, their values, their ethics is important to the human trusting the AI and being willing to accept its advice. But then the tension there is, well, what if the AI knows better, in a sense, right? What if the AI understands that this is a situation where this particular human is not as well prepared? And when are you aligning in order to gain trust? And when are you, to the right extent, helping to lead the human away from what might be their natural inclination?
An example, so just maybe think, so all of the chemical warfare agents, there's a zillion of them, and we have to, everyone in the military knows, you have to take those like online courses and try to remember, what's a blister agent, what's a nerve agent, what's a biologic agent, what to do if they have, salivating, or if their pupils are dilated, or if they're seizing. And it's like memorizing the Krebs cycle. Like, you can pass a test and then you like completely forget it afterwards, and this is one of our biggest threats from our adversaries, and it's almost impossible for any medic or physician to remember what to do in those scenarios.
Yeah, that hip pocket access to information is so important. And when I think of AI, though, and where it's going to help, I see two key areas: triage and resuscitation. Can AI, again, help me decide who goes on the vac? Can I sit on this guy? And again, I can't, because we're getting bombed by long-range precision fires in Ukraine there at that facility. You have to keep moving. And if you've got 100, 200 people sitting there and you can't move, then you're a target, right? But then in addition to triage, it's resuscitation. And so we see that as really important. But the other part of medicine that's really important as well is the medical logistics. And I don't want to lose sight of how critical it is. If I'm going to put somebody on an unmanned vehicle, ground or air, and send them off with equipment, that's less equipment I have back where I'm at. And so how do I get resupplied? So the concept of fly or drive in vehicles with supplies, Class 8 medical or whatever, and then unload and load with casualties, and off they go. And then resupply is so important. So the med log piece of the medical future on the battlefield is linked to the care delivery piece.
But it competes with bullets and water, so it's, there has to be a balance.
And we've seen zip lines sending blood in Rwanda and other parts of Africa since 2015, 2016. I mean, it's just an incredible program where there was no infrastructure. And yet with drones, we can now provide life-saving interventions for, postpartum hemorrhage, trauma, et cetera, in parts of the world. Same kinds of trauma and hemorrhage we're going to see on the battlefield.
Mm-hmm. So I just encourage the audience to submit questions. We're happy to take those as we go. We're going to work those into the discussion. So, please use the QR code that's up there to do that. JP, is there a thread that you want to pick up from the discussion, or another direction you want to move to?
Yeah, I'm curious and this could really be for anyone, but as we think about larger scale casualty situations, whether military or civilian settings, where you just don't have enough resources to deliver optimal care to everyone, or even to assess everyone in a timely way. How does that change your thinking about the type of decision support that's necessary? What are the psychological factors that come into play there? Maybe for our medical colleagues, how does that change your medical decision making and the standards of care that you apply, really for anyone?
I mean, also, as part of a project we did with Matt Turek and I2O, we interviewed the mass casualty team who responded to the Las Vegas shooting. Mm-hmm. And one of the first decisions they had to deal with, and really everything flowed from there, was assessing the degree to which the situation that was unfolding, and to degrees uncertain at the time, was going to be able to be comprehended and dealt with the pre-existing SOPs, tactics, and designs that they had in place that they had been trained in. And so I think as mass casualty events get larger and more scaled, the importance of that recognitional ability comes in. That's, I think, the fundamental first question of basically a mode switch of, can I deal with this with things I've been trained on and rules I have and the normal way, or do I need something new? And if we need something new, then what are the human skills that we are augmenting and supporting to help them actually have the cognitive freedom to do the triaging, to save their lives? And that is things in cases like that and other cases we've studied. It is innovation, it is adaptation, it is being able to quickly give people new roles, it is being able to scarcely move people around, and physical manipulation of the environment to help with the workload. Those are still core cognitive things that those triage doctors in that moment had to deal with, and AI can help with. But it all stems from the first fundamental question, which is this new, or is this the kind of thing I've got the experience, the packages, the algorithms, and the rules that I can deal with? Because the quicker you can get that decision right, the more time you have to plan, to prep, to get the environment ready to hopefully stop you from having to deal with that later on when you are overwhelmed and dealing with all these casualties and keeping them alive and doing the triage.
One of the paradoxes of mass casualty events is that the larger the event, the more delayed the medical response typically is, either from the ongoing threat of whatever caused the injuries, or just the sheer number of casualties. And so as we look at what we call a timeline of life-saving interventions, where you have to stop external bleeding literally within minutes. So you need to get blood transfusion on board within about 30, and you need to stop internal bleeding within about 60 minutes. And you just kind of think, well, in this large-scale event, who's going to be there? Who's going to be there in the first few minutes? It's the bystanders. We saw, like in Boston or in Las Vegas, those bystanders are there, and many of them are former military, putting on tourniquets. And the American College of Surgeons started this Stop the Bleed campaign to teach everyone, like they teach CPR, how to put on a tourniquet and stop bleeding. And so, that you think about what is going to save the most lives, it comes down to simple interventions early on to sort of like, we talk about act first and then triage. And so I think the AI is probably going to come in like in that triage situation. You have the tourniquet on, now what?
Yeah, I think the key, what we learned from the DoD and civilian is having a skilled first responder is so important. Having resources, blood and other things are so important, but that doesn't always happen. The Stop the Bleed program was critical because we're all in this together. And unfortunately in our society now, mass casualties, shootings, et cetera, are becoming fairly commonplace. And so we all have to be aware of what we can do. And that same kind of training is necessary on the battlefield as well. So there's so much other information that the civilian community can gather and help the DoD with, such as large pre-hospital data sets. We need good DoD pre-hospital data. We don't have it. So how can we get it? What is some kind of form factor? I'm wearing an OA ring, but is there something out there that could be a hardware, software solution that already fits right into the DoD information systems that allows me to capture information? Is there a need to get pre-deployment, garrison-based physiology data, right? So I know what Ron looks like on a good day, and then when I get whacked on the battlefield, there's a delta there, and can that make my algorithms even better? And so having that kind of data, just like we now do DNA swabs, there's DNA on every military member, part of the DNA repository, and we have serum repositories. So all these different things are going to be important. And to go beyond the golden hour. It's no longer the golden hour, it's the golden day or the golden week. Because as you sit on someone in a prolonged care battlefield setting, for the next day or two, you're not dealing necessarily with sepsis. You could be, but now you're dealing with a completely different problem that you were not familiar with. You're getting now bacteria, viruses in the bloodstream, acute lung injury, acute kidney injury, multi-system organ failure. Now you're just overwhelming your resources for one casualty because you couldn't get them out quick enough, right? So all those things come into play in both military and civ, and I think whatever we're doing in civ really applies to mil. The tragedy is that there isn't an NIH tranche of money for trauma, right? And so finding that, and it's so good to have DARPA focusing on trauma because it helps inform everybody that we need more funding to do this kind of research.
I think, when I think about a civilian mass casualty event, right, you mentioned the Stop the Bleed campaign, you have your Aura ring, right? Those are pre-positioning, whether it be knowledge or sensors. I'm very interested in, what can you do that doesn't depend on that pre-position? If you have a civilian who is uninjured, but next to someone who is injured and they don't have the benefit of having, received the information from the Stop the Bleed, how can an AI platform right there with them help, walk them through those simple but preliminary steps, and also help them overcome what is going to be a very stressful situation for them, right? I don't know, how many people are, just naturally ready to dive in and start offering military care to someone who's seriously injured. If the AI can help with that choice first, right? The choice that I'm going to do something, and then help give them the confidence to do the right things, and help prepare them for the long-term mental health impacts of being in that situation, which I think is important. I think that's a potentially valuable thing. And then if there's another way that autonomy can be doing broad sensing over a mass casualty event, and for everyone who doesn't have an Oura ring, can we tell if they're moving? Can we tell if they're breathing? Can we tell if they're bleeding, right? And provide that to maybe first responders to help better prioritize who they're going to in what order. Those seem like opportunities for those kinds of events.
So we have some really great questions coming in from the audience here on these threads. And I want to quickly go back to the first audience question that came in, which was regarding data. And the question was, where can researchers go to find medical data, DoD data that would be useful for understanding what sort of technological needs there might be. And Stacy and Ron, I know this is very much in your area of experience. So any suggestions for that?
Well, probably the main data source on battlefield injuries is in the DoD Trauma Registry, and that's run by the Joint Trauma System, which they have a process for requesting data and data sharing, like any other DoD organization. But that information is available to DoD researchers. The problem with that data is there's a lot of gaps in it, which relate to challenges in actually documenting and capturing care that was done, which is probably one of our biggest gaps right now that we would love to solve, is just a way to actually capture that physiologic and intervention data, especially early on after injury.
Well, we have at the University of Pittsburgh and the University of Pittsburgh Medical Center a lot of pre-hospital data, which is being shared with the DoD across numerous research portfolios. And I think that's really important to build that out, because when you have real pre-hospital data, and it's all penetrating or blunt trauma, 18 to 50 years of age, waveform data, voice, video, A-line data, a lot of really important pre-hospital data. What's nice about that is when the DoD, like at the Institute for Surgical Research, is working on a compensatory reserve insufficiency monitoring capability, but they've never tested it on real human data. They come to us and we say, okay, here's 500 trauma patients, anonymized. You can run your application on real trauma data, real time, and we'll see how well it is in predicting. So we've got that project going on. We've got other projects with DoD developing AI algorithms to do not only treatment and triage, but diagnosis. When you're on the battlefield, don't forget, it isn't just trauma from, blunt and penetrating trauma. There's all these other threats, such as weapons of mass destruction, directed energy. All of a sudden, you got a lot of different people acting strange, having severe headaches, hearing noises. How do I know that's directed energy versus something else? Acoustic, laser, microwave, and all these different things are now threats to us. These are weapon systems that we need to respect, just like we do chem, bio, radiologic, and nuclear.
So we had another audience question about, are there AI or other technologies that can help bystanders, help turn them into more effective first responders? Stacy previously had talked about training, but Mike, I kind of want to combine the training and the AI topic.
Yeah.
Are there AI approaches we could use to help train the population much more broadly in some of these first response capabilities?
I think certainly so. I think, one of the really interesting questions there is from a knowledge and what's the best choice for the situation perspective. I think the medical community has, from my understanding, way more knowledge, way more understanding about what the right thing to do. The problem there is, how do you help that person understand what all the knowledge says is the right thing to do, and then how do you help them overcome the stress of the situation and actually do those right things. So training is an opportunity. The more of this you can do in advance, the better. The Stop the Bleed campaign is one great example of this. But I bet everyone in the audience probably has an iPhone or an Android or something, right? I don't know how many of you have a first aid app, right, that you could pop open in the event of an emergency and start to use, or you could use in your spare time to understand, right? There's the knowledge is there. It's just convincing the population to take the time and understand the importance to learn that, right? My son recently completed his his CPR training, right? Great. He didn't do it until his summer job required him to do it. So how can we build it into more kinds of things where this kind of training is just a regular part of what you're doing with your other life? And then obviously you can use AI to help supplement the human instructors to provide that training cost effectively.
So there was also another question about situations where immediate evacuation is not possible. So what sort of beyond AI solutions, are there other things that we should be looking at in addition? How should we be thinking about those sorts of situations? I think Ron or Stacy maybe to start that one.
Yeah, for delayed evacuation, there's a lot of efforts in training. There's a lot of efforts in developing guidelines that are appropriate for that situation, so that they can fairly easily look up the guidance. And then there's a really big focus on telemedicine, so that you can get that real-time, higher level advice as long as you're able to get a phone connection.
Yeah, and so I did a lot of telemedicine in the Army for over 20 years and deployed it to 20 time zones, and I'm very familiar with that. And you got to worry about the RF signals you emit. I mean, anesthesia machines emit RF, and so is that RF frequency the same as what the warfighter's RF frequencies are? And that's how they find you on the battlefield and do long-range precision fires to blow you up, right? So I think more and more telemedicine was a big deal when I took it to Somalia in 1993. It continues to be a big deal with COVID. We know that, and I think that will always be there. To the extent that AI and telemedicine augment that clinical care in a prolonged care setting, it just augments it. It never replaces unlimited supplies and resources, right? But it is what it is. You don't have supplies and resources. You don't have skilled neurosurgeons trying to determine if there's a bleed going on in the head, which is explaining why this guy's not waking up. I mean, there's all sorts of things you don't know. When
I do telemedicine consults, it's exactly like that. You're like, did you think about this? Did you get a neurologic exam? What are the vital signs? It's basic, questions, and they're like, oh, okay, yes, I'll do that.
Yeah.
And, it could pretty easily, a lot of it could pretty easily be automated.
It can help, for sure. And so I think there is a lot of value to AI to augment the telemedicine, because you don't want to send off an RF signal. You don't want to talk. I mean, guys are getting killed in Ukraine because they're on cell phones, right? So you want to be very careful about that on the battlefield setting. But I think it's being able to use AI to tell me, predicting, okay, this guy is really sick. Now they're starting to look septic. Now I better start giving antibiotics, or I better start taking them back in the OR and do another wash, wash out and bring them back. So these kinds of things there's no simple answer for that question, because there are so many constraints that you're dealing with. But I think the future is how AI as a tool can augment when there is no evac, when there is no resupply. What role, if any, does it play? I don't think we know, but I think we have to explore that, because I think we will learn from that experience and then figure out a role eventually where it has that capability to augment care.
Mm-hmm. So one of the discussions that we've had before, and we're going to probably need to wrap up here in a couple of minutes, was around things like policy, right? So that's written in a sterile environment. Maybe it's right 80% of the time, and wrong 20% of the time. Are there things, Mike, that we could think about from an AI perspective that we could do to help with that? And then maybe Neil, is there some quick thoughts on how that might support human decision making?
Yeah. So my view on things like policy doctrine, right, is one of the constraints on that is how much hopefully can a human learn and retain, right? And so if we didn't have limitations on how much humans could learn and retain, we could write policy and doctrine to cover lots and lots of situations. But we gotta pick a constrained chunk of knowledge, and that means, as you said, that you pick the knowledge that gets you the right decision. I'm throwing out numbers 80% of the time, at the cost of probably being the wrong decision 20% of the time. So now, if you bring AI decision support into the mix, suddenly you have this whole nother memory, this whole nother set of knowledge that, if it's done in the right way, you can apply, and suddenly that 20% becomes opportunity for improvement. if you can build a system that gains both the trust and the acceptance with that local caregiver, but also the institutional trust, and right. So you got to get the policy shop on board with this at the same time as you get the individual caregiver on board with this, and so that brings in the human side of this yet again.
Well, I mean, I think when we think about policy and developing policies, one of the issues that you see when you study kind of past decisions in high uncertainty environments, I'm thinking here of things like the Grenfell Tower, the issue was not the policy itself. The issue was the over-reliance and unquestioning of the policy in a new environment, because the policy gives you confidence in the sense that you know what you're doing. And so sometimes it's the misapplication of policy, which is driven not just by cognitive issues, but physiological issues, and the stress of the environment. It can cause narrowing, it can cause cognitive closure. And so sometimes I think maybe some of these benefits of AI are actually understanding when it is right and wrong to apply policy, and perhaps the nuances around policy to environment fit, to allow the person that space, that cognitive space, that physiological freedom to actually be able to make the best decisions they possibly can by helping where they are. The second point I think is really interesting is the idea of developing an AI that's right 80% of the time and 20% of the time. I mean, I've had the privilege of working in many environments with people who make very, very, very difficult decisions. And the first thing that strikes you sometimes is there are 20% errors they are unwilling to accept. Mm-hmm. And so how do we now navigate that with AI? When the AI may be saying or encouraging decisions that violate principles or morals within the human that they are unwilling to have violated. And that's an in-the-moment decision problem, and I think Mike alluded to it earlier, that's also a recovery and a trauma problem as well. And so this idea of acceptable misses and acceptable errors in these environments, in the domains we're talking about, that's also a significant challenge that we need to be thinking about.
Yeah. So I think that's a great tee up for follow-on discussion. So catch us at lunch, catch our panelists at the breaks. I'd love to talk more. We're out of time, but please join me in thanking our panel.